Go ahead, Chair.
Okay. Good evening, everyone, and good morning for those who are watching from elsewhere. And good afternoon to those who could be in their afternoon, wherever you are. I wish to welcome you. I wish to welcome you to this webinar by ISSUP Kenya. It is a great opportunity for us to host you for this important event. This event has been put up on this very important global day, the World AIDS Day, knowing that this HIV is a big challenge, and as the globe commemorates the people that we have lost to HIV, and also celebrates those who are making great efforts in staying in treatment, ISSUP found it very important to join the global community to be a part of this event. And for you accepting to be part of this event and being here this evening, I really want to say thank you on behalf of the ISSUP Kenya. This event is streaming live as well on Facebook. You can alert a friend, you can alert a professional somewhere, you can alert anyone in your networks, so that then we can have as many people as possible being able to interact in this way. This evening, we have a number of panelists who have different experiences in the area of drug demand reduction, and of course, working with the populations of the people using drugs or the mental health issues, as well as in the HIV world. I will allow them to introduce themselves at a certain point, but before then, I would wish us to watch a small video that introduces us to ISSUP, so that then we can be able to be in one accord, and then we can be able to move forward. So Albert, if you don't mind, kindly play the video for us.
Yes, give me a second, Dr. Give me 2 minutes, please. While I find.
Okay. Even as we wait for Albert, I believe all of us, in a certain way or another.
Is an international.
Go on, Albert.
Yeah, let me just share the screen.
ISSUP is an international professional society that connects, unites, and shares knowledge across the global substance use prevention, treatment, and recovery support workforce. A key element of ISSUP's work is our international network of national chapters. They connect ISSUP members in their own countries and help adapt the role and mission of ISSUP for different languages, cultures, and environments. National chapters bring together the prevention, treatment, and recovery support workforce at the national and local level. Each country presents its own set of challenges and opportunities for developing a trained and well-connected workforce. Our approach involves partnering with local organizations to establish national chapters that offer a wide variety of activities to those working in the field. National chapters act as a focal point where members can get knowledge, training, and valuable networking opportunities. For example, they provide members with a space to learn from experts in their own country and share knowledge through online webinars and in-person events. They also help to change the way that research is communicated and used by the workforce. By guiding and supporting effective research engagement, national chapters make a vital contribution by helping to ensure that research evidence reaches and informs policy and practice. These are just a few of the ways ISSUP national chapters are making a difference, and we invite you to join us in shaping effective, ethical prevention, treatment, and recovery support services where you live. It does not matter what stage of your career you're at, we look forward to welcoming you. Becoming a member is free and it's easy to apply online. Visit our website to learn more about our national chapters and the benefits of joining ISSUP. ISSUP is an international
Thank you. Thank you, Albert. I am sure now all of us, to some extent, have a view of who ISSUP is and what ISSUP does. And I wish to really say that we have a big responsibility, especially our nations, to ensure that issues substance abuse are well managed professionally, that we professionalize this field so that then services can be delivered quality for the good of our population. As you are aware, this evening we have a number of panelists. I wish to welcome you to this webinar by a number of panelists. I wish to welcome you to this. Okay, there seems to be some kind of echo. I want to request the panelists one by one to just put on their video and introduce themselves so that then we can be able to move on to the next step. Kindly, not in any order. Boniface, tell us who you are and which institution probably you represent.
Yeah, my name is Boniface Ndirangu. I currently the chairperson of the Addiction Prevention Rehabilitation Association of Kenya. It's the essentially owners of rehabilitation centers across the country who came together. I'm also recently elected to be honored to be a trustee with ISSUP Kenya, a role which I'm very grateful for and looking forward to play. I'm happy to be here and thank you so much for inviting me to be a part of this.
Thank you, Boniface. the next panelists. Paul?
So good evening, everybody. So my name is Paul. Many people know me as Paul Ndungu, but you can see I'm signed in as Kirungu. So Kirungu is my middle name. So Ndungu is my father. I can see Bonnie did not know that. I work for an organization called Genesis Sober Community, which is a rehabilitation center that houses people of both gender. And I am here today, and I'm very happy as a member of ISSUP. And I have been in this field, of course, for a number of years. I have met many of the people in this field. I met Bonnie. I'm very happy to see him. He's been a friend of mine since 2007. That's correct, Boniface? I think 2007. And I think I met you, Pamela, almost at the same time. And the other panelists who are also here with us. And it's my pleasure to be in this panel this evening. Thank you.
Thank you, Paul. Can we have Grace introduce herself?
Thank you. I'm Grace Wanjiku. I'm Director Counselling Services in State Department for Public Service. I'm also a commissioner in for the Global Center and Credentialing and Certification Commission for Addiction Professionals. And I'm also the chair for the Training and Credentialing Committee, ISSUP chapter. I can also say I'm happy to be in this forum where we'll be able to share information, and I guess all of us will learn. So this is just an interactive forum where we just want to share issues that relate to World AIDS Day. So I am also very happy to meet all of you, and I hope we'll have a very effective forum this evening. Thank you.
Thank you, Grace. Can I have Dr. Tom introduce himself? Dr.
Good evening, colleagues, and welcome to the webinar today. My name is Dr. Thomas Obulutsa. I am a counseling psychologist. Currently, I'm the program director at HIAS Kenya, and I'm glad to be here with us.
Thank you, Dr. Naomi. Are you already in? Kindly introduce yourself.
Yes, it seems a bit dark. My name is Naomi Mulee. Can you hear me?
Yes, we can, Naomi.
Can you hear me?
Yes, loud and clear.
Okay. Hello, my name is Naomi Mulee. A community and health psychologist.
Yes.
I'm a community and health psychologist, and also an addiction counselor. Yes, and welcome to this webinar.
Great. Okay, and myself here, Dr. Pamela Kaithuru, privileged to lead this great group of ISSUP Kenya. I'm a counseling psychologist based in Nairobi. So to move forward, I need to be able to tell us that today, as we are aware, was the World AIDS Day. Sorry, there's some echo somewhere. Today is the World AIDS Day. And as ISSUP Kenya, we felt important to celebrate this day with the world. The theme for the World AIDS Day 2022 is equalize. And in Kenya, of course, we interpret it as sawasisha, intended, aimed at ending the triple threat. We know that the World AIDS Day started being celebrated in the year 1988, and it's celebrated every 1st of December as a show or to remind communities to renew their commitment to actually ending AIDS as a public health threat. And every year, the World AIDS Day is given a new theme. And as I've said, the theme for this time, for this year, is ending inequalities, whereby, as we are aware, Kenya reported its first case of HIV around 8 years ago. And since then, a lot has happened in the nation through a multi-sectorial approach of coordination that has been led by the Ministry of Health, the agency National AIDS Control Council, which has spearheaded these interventions across the country, bringing on board all stakeholders in policy, as well as resourcing, and also ensuring that studies are done to inform interventions. And this has actually helped our nation to lower the prevalence to a very good level. Today, we are talking by the statistics of 2012, we have declined from 9.1% to about 4.3%. In the same breath, new infections have actually reduced, that now we can talk of about that 4,540 new infections annually by the research, the study of 2021, which is a very big improvement, considering 100,000 people annually to HIV. Another indicator that has really been of importance is that as a nation, we have about 1.2 million of the population of the people living with HIV being put on treatment. It is a very good thing for the nation. So as we mark this important day, we have a lot to celebrate, but also are reminded that the indications recently are showing an upward trend, especially among some cohorts like the young people. Another recent development is the renaming of the National AIDS Control Council to the National Syndemic Disease Control Council, which has an expanded mandate now to coordinate and ensure that the interventions among the syndemic diseases is being handled so that it ceases to be a public health threat. So the syndemic bit is because of the fact that there are other coexisting diseases with HIV that are resulting to increase disease burden in the country. And for this case, this includes conditions like TB, sexually transmitted diseases, sexual and gender-based violence, and a lot of other challenges. And therefore, the focus this year has been the triple threat, where the triple threat focuses on ensuring that we are looking at HIV as well as pregnancies among the young girls, and also sexual gender-based violence. Indications are, or studies have shown our young children such that the cohort between 15 to 29 are contributing to a high number of infections. 52% of the new infections that were reported in the recent survey was actually between age 15 to 19, which are our young people in school going and also colleges, really painting not a very good picture for our country, especially looking forward. And there is also notable increase in the deaths occasioned by AIDS. And therefore, as ISSUP, it is important that being the organ that is mandated or with a mandate to really handle issues, substance abuse, ensure that we are making this profession noticed and contribute to the development of our nation. And knowing that there is a relationship between substance use and HIV, it was important that we have this discussion. And as we have already introduced our panelists, I would like to roll it out to the panelists by trying to indulge them to give us the correlation between HIV and substance abuse. I think for us.
Okay, so thank you very much, Pamela, for the introduction. I think I will begin by talking about the importance of addressing substance use disorders in the treatment and sensitizations on HIV and AIDS. My experiences, first of all, let me share some bit of experience. 2007, I was working in Maisha House, where we were attending to injecting drug users, people who are homeless from downtown Nairobi, Mathare, Korogosho, Huruma, and Kawangware. And what I found out is that quite a number of our patients were testing positive for HIV. And the key reason for that was because of injecting drug use. And I remember even with you, Madam President, we did go out together, I think for almost one whole week in places where people heavily abuse drugs. And we found out that there is a very big chunk of people who are HIV positive. And therefore, the conclusion of the sensitization and the research that followed was that heavy drug use has a very positive impact on, a very negative impact on drug HIV infections. And of course, we know when people are drunk, say for example, they've been drinking alcohol, of course, in their inebriation, people loosen their guard. We know alcohol impairs judgment. It does incapacitate decision-making. And therefore, people find themselves behaving irresponsibly sexually, having casual sex with people they've just met at the drinking joints or the drugging joints without using protection, multiple sexual partners, and other increased risk behaviors. And therefore, the rate of infection is quite high on people who drink alcohol as well as other drugs. Of course, I've mentioned about people who share needles and syringes. If one person is affected and they are sharing the needles and the syringes, of course, there's going to be a lot of infections. And of course, IDUs are known to be at a higher risk of getting hepatitis C virus, which in turn makes it harder to treat the HIV, because of course we know the drugs that we take have to be metabolized by the liver. And of course, these drugs will impact on the liver in a negative way, which means if someone is a substance abuser, of course, drug use will impact on the liver negatively. And then they are also on ARVs, then that's a double tragedy on the part of the liver. And of course, that's going to complicate treatment. And of course, when people are high on drugs, they will be able to pass the virus to other people, because people lack empathy when they are drunk. They don't care about how their behaviors are going to impact on other people. And therefore it becomes very easy for people to pass on the virus when they are either drunk or drugged. And of course, drunk people are less likely to follow through HIV treatment than people who are otherwise. If, say, for example, I'm supposed to be taking my medication, that's HIV medication at this particular time, and I'm in the bar or the drug den and I'm drinking, it means I will not be able to take my medication as prescribed. And of course, we know substances of abuse do lower the body's immunity, even without the HIV. And we know drug use does kill people. That has been killing people. We know that as a fact. And therefore, if I am going to have lowered immunity, it means I'm increasing my chances of infection if I was to be exposed to the HIV virus, because my immunity is down. And of course, drug use can directly damage the liver. Of course, I've mentioned about that, which is going to complicate treatment. And of course, there is the aspect of transactional sex, where people are going to trade sex for drugs, or either for money to sustain drug use. We know drug use is a very expensive exercise to be able to do alcohol every day, or even to do a drug like heroin every day. And people are not working. It could be girls, it could be men having sex with men. Of course, people are going to trade themselves so as to be able to access the drugs. And of course, there are also people who have been known to sell the ARVs to access money for the drugs. I used to have people who would share these experiences when I was working in Maisha House, that they would go and sell their ARV drugs because they needed money for drugs, which of course will mean they forgo the medication, which is going to, of course, impact on their health in a very negative way. And of course, when people are high on alcohol, they do not know where they are. They are not fully conscious about where they are and what is likely to happen. The same case with drug use. People expose themselves to rape and even sodomy. And we have seen videos of people whose drinks or the whatever was spiked with drugs like Rohypnol and to facilitate sexual orgies. And of course, if a girl is being raped by about 5 or even 10 men, the chances of her getting infected by HIV are quite high. We have men today who are being sodomized. And most of it happens when they are drunk, or when they are drugged, or possibly when they are walking at night and they are coming from the drug dens. And possibly at that time they are very weak. They cannot be able to protect themselves. So we can talk and talk, but the fact of the matter is that if we do not address issues of substance use, it might be a huge challenge to be able to achieve the goals of zero transmissions, because drug use is central to the infections of HIV. It complicates treatment, and therefore it is important. Even as we talk about HIV and AIDS, we also bring on board the issues of substance use disorders. Thank you very much.
Thank you for that elaborate insight. I would want to bring Grace on board. She has been working with the public sector. Probably she can give a perspective from the public sector group.
Thank you, Chair. And thank you for Mr. Ndungu for what you have shared. And I'll just add on the correlation between HIV and substance use. Of course, for most of the things that Mr. Ndungu has said, they also relate to the public service because we all know that substance use and addiction normally weaken the immune system, meaning they cause immune suppression. And HIV itself also damages this immune system. And this makes it very hard for one's body to fight the infection. And this has been also a challenge, quite a challenge in the public sector, and to an extent that whereby we have found it necessary to speak or to you when we are applying the two policies that address these two issues, which I happen to run both of them, the HIV policy and also the substance or workplace substance use policy. You find that quite a number of the employees that also seem to have a lot of challenge in substance use. When they come down to real counseling, you always find that, or when they go for testing, they also tend to have the virus. We are not saying that everybody who is using who has substance use or addiction has the virus, but that has been a correlation. And even when you look at what we are now calling uncommunicable diseases, you find that this is becoming a challenge, and especially because in the public service, when we are talking of these issues, they tend now to complicate the mental health of the workers. There is also the evidence that the substance use normally hasten the progression of HIV and its consequences, and especially a lot of challenge challenges in the brain. And this in itself becomes a challenge, especially because the substance use that interferes with ART, or what we would call drug adherence, and you find a lot of relapse, or it ends up even affecting the employees that sometimes may have addiction, and we would recommend rehabilitation. So you find even even when we want to really help these employees so that they can be able to deal with or maybe be able to manage or cope with the virus, you find those that use the substance use, it becomes very complicated, and it is a whole thing that if you are managing such an employee, one would need to have the benefit of being able to integrate more than just fixing to one area, because you realize one of them will actually trigger the other or affect the other one in one way or another. It is also clear, even when we are helping some of the employees, that even when they come, especially the HIV patient, you realize sometimes they are able to progress. You can actually record very good progress, but sometimes those that use the substances or drugs, you find that they end up having fluctuating, response, and obviously confirming that that drug use and addiction may increase what we would call viral load, accelerate disease progression, and sometimes worsen AIDS-related mortality. And that is a loss when we are talking about the public sector. So I just want to say that this is a challenge, but again, in Kenya, we appreciate the fact that we have been able to have the legal, even the policies that speaks to these two issues, and we are at a level whereby we are seeing the need to actually ensure that we build a capacity that can be able to manage these illnesses, because the way things are, it is not very fair that they can be managed by somebody who is not, who doesn't have the skill. So one of the challenges is to help ourselves, whether it's at the public sector or the normal public, to actually be able to see how we can understand the science behind all this, because sometimes if ignorance makes it even more complicated. So basically it is therefore important to speak to these two issues because they are positively correlated, and you cannot deal with HIV addiction or substance use or the other challenges that we want to address today, that is the truth, and therefore it is important for the caring professionals to actually see how they can even try to understand more. Because if somebody is just specializing or in substance use, and you have somebody who is also having the virus or the non-communicable diseases, then you realize you can only offer that so little. So it calls all of us, therefore, to up our game. It doesn't matter where you are. There are some basics that all of us require, whether you are a mother or whether you are a manager, whether you are a line manager. There is some level of knowledge and the skills that are required for us really to be able to manage the HIV, and especially the new infections that we are discussing today, and also the challenge that we are having, especially in our country, in substance use and addiction. Thank you.
Thank you, Madam Grace, for bringing us to the know of the fact that as a nation, we have policies that speak to the two conditions, to the health of our public. And I know that Boniface works very closely with the young people and the community. I don't know what you would say, Boniface, concerning this relationship between substance use and HIV. What is your experience at the community level?
Thank you very much. Many of you are aware that I speak from a level of experience, and I like sometimes to really fall back into my own experience as a former drug addict, alcoholic, and trace back a lot of these issues. And you realize, and I do, that sometimes it is not even addiction per se, but the initiation, the first time use for a number of people, especially between the ages of 16 and 17, going all the way to 20, 21, if it is late, that can be a very dicey area or a space where the first time use, and some of them become traumatic experiences, which almost we never get to know now what led to what, that the trauma now leads to. Because if the things that Kirungu described, yeah, if those things happen, and for a lot of our young girls, we are sure that the first time they lose their virginity, it is probably organized by a friend in a small house party where the boys have spiked the drink, and there is a likelihood that sexual activity will be done for the first time. I know quite a number of people who have had such traumatic experiences, especially the younger people that we are seeing in coming into rehab at a very young age. Most of it, we will see a correlation between a traumatic sexual experience and that now leads to uncontrollable change in how much they drink or how they drink to try and forget that bad memory. So, and as Paul has also mentioned, it is not just with girls. Boys have become victims these days. The correlation, it is not a surprise to me to hear that as we experience a younger group of people checking into rehabilitation centers, which I'm the current chair with over 100 members, we are realizing that there is as a younger population of the age of admission is going younger. I don't know whether you are seeing that at Genesis, but quite a number of young brackets below the age of 19 and 24. And that is an age group that was not previously, was the outlier group. The younger they were, the fewer they were a few years ago. 10 years ago, there were fewer people below 24. Now they're beginning to form the critical mass of people checking into it. So if we were to see that there is also a relation between that and higher numbers of HIV in the same age group, then there's no doubt that, and a friend of mine was describing this to me earlier today, as the glue that brings together these behaviors, risky behaviors, it's just what Paul really put together. The alcohol, the miraa, the momoka, the marijuana on the side, and these days it's almost like a poly addiction rather than one. See a number of them at the same time, and the risk that comes with. I'm also reminded today by Paul of the injecting drug users and how they share needles, and I'm one of them. And somehow I learned like in my 4th year in recovery that I was hepatitis C. I had tested for HIV. Somehow I escaped that. I don't know how I escaped, but hepatitis drug users get it. And for the time that I got it, I knew that I had hepatitis C. It was almost like a death sentence because there was no cure to it. Now they developed a system where they give us medication for hepatitis C, and now we have the medication. And I think this also contributes, just the knowledge that you have within you, a disease that you have to either take medicine for the longest period of time or live with for the rest of your life, contributes to some of them giving up on themselves or even giving up. So I don't know, Daktari, if I have shed some light into that, or just my observations about the younger version of people checking in with and I'm also very grateful for this focus of the twin issues, because they almost come together. Traumatic incidences, substance abuse, HIV and AIDS, and other STIs, and a combination of poverty, and you see a snowballing of something that has to be dealt with from quite a number of different angles rather than from one angle. How we have been dealing with it, from what I gather from Wanjiku, a lot of us are seeking help from the HIV world to get courses and bring people in to speak about HIV without forcing our clients to do tests, encouraging them wherever possible if they would like to do a test, supporting those who are on medication to stay on medication, bringing up the awareness around our sexuality, in rehab centers, especially for those rehab centers that have both male and female clientele. And we see a lot of that kind of challenge and promiscuity, even among people who have stopped using alcohol and drugs in a rehab setting. I don't know whether Paul has the same experience, but we see that we have to be really cautious of what could be going on between some of our female clients and our male clients. So we have to really watch over that. And interestingly, sometimes is when you know for sure that one of them has HIV, and yet you cannot divert such information. Yet you have to protect your environment. So it becomes a very tricky, dicey area, and is that becomes an area where you have to take all the professionals together, and manage that. And that's why no wonder many people these days decide, hey, no, at my center I'm going to have one sex, one a male only, yes, or female only. Usually male only, because very few female only rehabs survive the market forces. Yes. And let me shut up for now. I'll talk up later maybe if I'm asked. Thanks for letting me share.
Okay, thank you. So,
wow. Thank you, Boniface. I see Paul has raised his hand. You could say something before I bring in Naomi.
Okay,
Paul?
Thank you. Yes, thank you. So I want to agree with Boniface, just the populations in our treatment centers. We have younger people than previously. And I wanted to, as Boniface was speaking, I was thinking about how the two complications worsen each other. That someone who has been sexually violated will turn to alcoholism or drug use for consolation. And then in the process of the drug use, they end up becoming more sexually violated. And then because of the traumas that come with it, then they want to drink and to drug more. And then in the process, expose themselves more to more sexual violations. The larger majority of all the girls that we have admitted have talked about being sexually violated. We have a few cases of men who are bold enough to also come out and tell us how they were sexually violated, sometimes when they were very young, by people in the family, drunken relatives. But again, they were not assertive enough to talk about them. So that aspect of where people will do drugs because of the violations, and then they get more violated, and then they drink more. So the two complications will keep on fertilizing each other and worsening each other. So basically, I think we are coming back to what we said, that if we have to address this issue, then we must also be in a position to address all these other issues, because somehow they are very intertwined. They go hand in hand. Thank you.
Thank you for Paul for strengthening that. And I'm realizing that in the midst of it, we are opening up other areas that we may have to call ourselves to discuss at some point, especially the area of the ethics and how even the interventions are being undertaken. But that is for another day. Let me allow the panelists and Naomi Mulee to just share our experience working with the communities. Naomi.
Thank you, Mrs. President. I hope I'm audible enough. You can hear me? Can you hear me?
Yes, yes, we can hear you, Mulee.
Thank you. I have worked in the area of HIV for the last, I just thought about it, and it's now 30 years. And that's from the time, from 1992. And that's when I was trained as a HIV/AIDS counselor. And I've seen the issue of HIV evolve over the years. And when you look at today, what is happening, I can see, yes, we have really come a long way. And despite all that, we still have challenges. And as I was listening to the students who have just finished their class 6 and class 8 exams, it was worrying that quite a number of them are already pregnant. Some were giving birth as they were sitting for the exams. And now when you think about the issue of HIV and AIDS, and you think about this maybe class 6 young girl, we are talking about 13 years, 13 to 15 years. So that again brings us to think about the issue of HIV infection, the new infections, because if this young girl has already gotten pregnant at the age of 13 or the age of 14, and many of the data that we are having, we are talking about 15 above, over 15 years. So I think we are still having a challenge in terms of data of the younger ones who are less than 15 years now, who are getting pregnant, and they're also exposed to HIV/AIDS. And so when we think about the issue of HIV/AIDS, as you had said earlier, we realize that quite a number of young people are contributing to high infections of HIV in this country, and as compared to the young men of the same age. And therefore, there are so many things that we really need to look into. What my former colleagues say, the issue of young people getting even to addiction, and also they also exposed for young girls as much as young women. When it comes to the issue of HIV, they are more bothered about the issue of preventing pregnancies, unlike preventing HIV. And so they always go for one pill. They'll go for a contraceptive, to protect a pregnancy. Whereas when it comes to the issue of preventing HIV, and so when you look at the whole infections, as much as we may seem like it's, when you look at the knowledge and the actual being tested.
Mulee, your voice is fluctuating. If you could try and stabilize your voice, there's some bit of fluctuation.
So you can hear me now?
Yes, now you are clear. Okay, thank you.
I was just trying to explain that when you're talking about we have the new infections are greatly the bigger picture that the new infections are among the young people, the adolescent and the young people. And so when you look at it, I was trying to explain that if our young girls are getting pregnant less than 15 years, then we also have the adolescents in high schools. We have had issues where young girls, when they go for midterms, instead of going straight home, they are having bashes everywhere. And what is happening? So the issue of infections is going up and up. Yet we have the knowledge in terms of HIV and the transmission modes, but the behavior is not correlating with the knowledge that people have even today. So HIV infection is still, we cannot say we really have the information data in terms of the total number of people who are infected, because we still have a big chunk of people who do not know their HIV status. Others may end up knowing their HIV status because they have been sick or they are sick. Now, when they go for treatment of these other conditions is when they know their HIV status. So the other challenge that is there, the issue of testing. Some people do not want to test because they are afraid how people will treat them. So issue of stigma is still with us. Stigma is still part and parcel of us. Maybe the time I went over, I was talking about our young girls who are preventing pregnancies and not protecting themselves from getting HIV/AIDS. And then you look at the issue of socioeconomic factors. Our young men are currently having the older women. And then the young ladies are also having the older men. So as it is now, you will find that HIV, the new HIV infections is now coming to the homes. In fact, we are saying almost 40% of the married stable couples are having HIV infections because of these other relationships that are coming on board. So the man will go out, the woman will go out, and they'll come back together. And then within our homes, when it comes to the issue of protection, who will tell the other one now, can we protect? Because the issue is there is this issue of faithfulness. So how will you bring in the issue of condom, even despite knowing kuna hii mpango ya kando? So those are challenges that we have to look at ways of how do we let people come out and openly discuss. Because as much as let's say is a woman who knows the husband has mpango wa kando, she'll not be bold enough to come and say, okay, now when it reaches this moment, then can we, use a protection, even vice versa. So again, the issue of HIV infection will continue within our homes as we continue that way. Now, when you look at the county prevalences, we are still having, nationally, we are saying that we are at 4.3% of the HIV prevalence. Yet there are some counties. Let's look at like Homa Bay. As much as nationally we are talking about 4.3% of the prevalence, a county like Homa Bay is still at 25.7%. A county like Siaya, we are talking about 23.7%. A county like Kisumu, 19.3%. So the first top 10 counties, the 10th one being Nyamira, we are at 6.4. So you can see, as much as we are saying that the HIV prevalence is still going down, but there are still some counties that the prevalence is still very, very high. Mm-hmm. So that big picture, when you look at it that way, then we still have pockets that have very high prevalences. And again, that now helps us now, even at the community level, to look out. What are the interventions that we need to look to do? What is it? Can we engage the communities more so that we can be able to reach those pockets with the kind of interventions? And right now, as I see it here, I want to believe that now the Hustler Fund will actually lift people's economic status so that they do not engage in behaviors that will continue exposing them to HIV infections. Yes, I wish maybe to reach there unless there's a question or. So basically we say the knowledge is there of HIV, but the behavior change is still missing. We have young people who are engaging in risky sexual behaviors because of socioeconomic factors. We also have the culture part of it. We also have the issue of rural-urban migration, again, which is exposing people to HIV infections. We have people who are going to work outside, leaving their families back. So what happens when this person is out there for a whole 1 year? Will that person actually be, by the time they come back home after one whole year or 2 years, we know people are going out of the country and the others are being left at home. So what is really happening? So at the community level, we really have big challenges, and we really have to look at ways or interventions to be able to reach the people down at the community level in terms of the infections, the HIV infections. Thank you, Mrs. President.
Okay. Thank you so much, Naomi. for sharing with us your experience at the community level. And actually, this discussion has brought up the aspect of transgenerational sex and exposures. And we know that the young people, of course, may not have the resources to purchase the substances, but by the fact that they are having sexual relationship with somebody who is making some kind of honey, then they end up also being introduced to substance use, even on the process of transacting sex. Another element that has come up is that we need really to look at how we can integrate all these and roll the services to the counties, because as you say, it is very clear that the prevalence is different from one county to another. And this is very revealing. And so I want to bring in one of us in the panel who would like also to share his life experience with this platform, to tell us his experience even as he works and interacts in the community. Mr. Mogo, could you please come on board?
Hello, am I clear?
Yes.
Yes, we can hear you, sir. You're not stable. You're not stable. Can you?
I can hear you. My life experience has been a bit tragic.
Okay.
Because I entered drug use at about the age of 19 years after I left secondary school. So after some time of about 4 years is when I learned my status. Hello?
Yes, we can hear you so well.
Okay. So as time went by, things became a bit complicated, because most of the time you can't believe what has happened. You've been in school, you've been taught very well, you're from the Catholic, and things like those you don't expect to happen to you. But with time, I came and joined this center, chapter. And at the year 2015 is when I came to agree to what was happening to my life, and joined Methadone.
Yeah.
And after joining Methadone, I took 2 years until the year 2017. I was weaned off, and I got a wife. And I think my wife has been very strong with me, because she was also negative. So it took time for her to understand my situation. But until at the moment we now have a kid, it was a very, very big problem.
Moko, we cannot hear you now.
Oh, I'm telling you about my experience with Methadone after getting clean and being able to manage my status and having to live with a wife that is negative, and also working with the community. I've had to work with people who have the same issues with me. I have to give them morale for them to understand how they're supposed to live. Yeah.
Okay. Go on, Mogo, we are listening. You can let us know when.
I think there's a problem with my network.
But at least you are trying. We can hear you much of it.
Okay. So my experience with the drug user community, the only problem is that most of the time after people learn about your status, there's just this thing that was being talked about a few minutes ago about stigma. So at the end of the day, you find that somebody was supposed to be taking their medication, but since people have learned about the person's status, people later migrate to other places. So even adherence becomes a problem. Yeah. Yeah.
Mugo, have we lost you?
No, I'm around. I can see you.
Okay.
Yeah.
Go on.
Yeah. So most of the time, the problem is only that this thing about moving from place to place. I speak
Hello?
Yeah, I can hear you. I don't know if you can hear me.
Okay. Yes, you are breaking at some point, but continue.
So the most of the time is that people migrate, so that's why adherence becomes a problem. But according to the way that we work with centers, the ones that we work with, even when somebody moves from one place to another, we are able to work with the next. Clear.
We can hear you, Mugo. Go ahead.
Okay. So my experience was a problem, but at the moment I'm okay. And the only thing is that at the moment there are new drug users here, very, very young drug users, of which we're not being able to capture. Yeah. Because according to, I think, to NASCOP, you're not supposed to capture people from under 18.
Mugo, are you still with us?
Yes, I'm still with you.
Okay.
Another thing is that most of our community members are not financially stable, and I think you understand that most of them are into things that are not very, very convenient with other people. So poverty also plays a very, very big role on our side. Yeah. Another problem, yeah. Another problem also comes when it comes to people that are taking methadone. Clinics have become, there are only 2 clinics, and some have to come from very, very far places, and it's also a very big issue with issues of transport. So you find that there are people that are supposed to be taking their medication, but since they're coming from far and don't have enough money to get to their places, they might miss for about a day or 2. So you see that does not assist anyone at all. Yeah.
Great. Okay, thank you, Mugo, for trusting us with your information. And as you can hear, really, friends, is that the situation is as it is. We still have a lot to do to help our community. We still have to focus or refocus our interventions. And as the mandate of ISSUP is, making it professional, so that we have standard services being offered across board, by ensuring that the people who are doing this work actually are people who are aware of what they are doing, considering that the science of addiction is rather new in the country, and it is very complex, as you can see, being complicated by many other health conditions, including socio-economic conditions, as you have heard. So I want to, at this juncture, invite us to maybe seek some clarification. If there is a question, if there's a clarification to be sought, maybe by a show of hand, we can have the panelists respond to some questions or clarify, or even as participants, we can also contribute briefly to what has been discussed. Anyone can start. It's an open or a plenary session briefly. As we think around, can I allow Mercy Musisi to say something? She is, if you are in the house, Mercy.
Hi, Pamela, and everyone else. Good evening.
Evening.
I think I've raised my opinions on the WhatsApp because I have been listening to everything that has been said, and I agree there's a lot that we need to do, especially I as a caregiver or someone who works in the treatment of persons with substance abuse and other mental condition, and we know that there's a link, there's a clear link where when it comes to issues, HIV, substance abuse, and other mental conditions. And I think it's time for us to it's a good conversation we are having, because it can help us form or get agendas moving forward, areas we can intentionally focus on in the coming year. And one of the things I've raised, listening to what the last person was sharing lived experience, I think he's not, it's an issue that I, as a person who works in a treatment facility, we've encountered a lot. One of the challenges is accessing medication for person who has transferred, because we know rehabilitation centers are all over. So sometimes you'll find that they need to continue with medication. They came with maybe with some or no medication at all, or they have been poor adherence along the way. They stop taking medication. So getting when you're trying to get them back to treatment for ART becomes a challenge, because you're being asked to produce their card. Some of them, they know the medication they've been taking, but they don't have the card. So getting the medication becomes quite a challenge. That's what was in the chat had said. Moving forward, probably we can have a sit down with the stakeholders or people that are in the institution of HIV, especially the CC programs, and see how to make it the process less cumbersome for this person who is in treatment, to get them back in treatment and continue with medication. Other than that, I think this is a very timely conversation.
Thank you, Mercy. Thank you for that share. Anyone else with a comment, a question? Paul, you've raised your hands.
Yes, I would like to support Mercy on what she has just mentioned about how difficult sometimes it can be for our patients to access medication. We have also gone through the same many times over, and sometimes hooking our patients to care also presents other challenges, because if we want to hook someone to a care that is near where we are, sometimes you find the caregivers in that institutions are hesitant because they know that our patients are with us for only a short while. And sometimes they will want us to be taking our patients to the care centers where they were introduced into treatment initially. And sometimes it can be very, very far. So I think moving forward is to look at how that can be addressed so that the patients are able to access care near where they are living. Even if they are to relocate, possibly there needs to be looked at what can be done. Because again, as Mogo shared, when people are in need and the points of access are quite far, sometimes people will not be able to get the help that they require. So I think that's an issue that I think needs to be addressed, as Mercy is saying.
Oh, great. Yeah, those, as indicated, are really areas that we really have to strategize. Because at the end of the day, we need to be able to have services closer to those who need them. I can see a raised hand by SAPTA Trust. Somebody using SAPTA Trust, kindly make your submissions.
Hi, I'm Dr. Bill Sinkele, the director of SAPTA. So I'd like to thank all the panelists for their very important contributions to this topic. I think this is very helpful on this World AIDS Day. And in particular, I'd like to thank Charles. He's a member of the SAPTA family, both for sharing his story and the work he does within SAPTA. So I think that is, I really appreciate Charles and I'm very proud of you. Maybe 3 points. One is there is a causal, not incidental or coincidental relationship. The more you drink, the more you engage in unprotected sex. So, so that's a really important point to keep in mind. And we also know that especially with alcoholics or those who have alcohol use disorders, there's a greater tendency toward violence. And so that, the impact of violence on HIV/AIDS is also very known. And the third point is alcohol and ART. We also know that when you drink alcohol and you're HIV positive and you're on ART, it reduces the level of ART in your system. It speeds up the metabolism. Others have talked about the problems of liver, but it speeds up metabolism of ART in your system. So you're having a suboptimal level of ART if you're drinking alcohol. So those are just 3 points I'd like to raise with all the other good comments from the various panelists and participants.
Thank you, Dr. Sinkele. And we are honored to have you here. Participants, Dr. Sinkele is one of the trustees for ISSUP Kenya. And these very experienced people that as a society, we want to draw from their experience so that we can also be able to grow this profession far and wide. Thank you, Dr. Sinkele. Damaris, kindly, the floor is yours.
Yes, thank you so much. Thank you, Mr. Ndungu. I will use Kirongo. I'm not used to that. And thank you for everyone else who has shared in this forum. So I'll say for the care and treatment, I've once upon a time worked in a CCC setup. And for such clients who are in the rehabilitation, once they tell you where they are picking their drugs or where they were picking their drugs, and you liaise with those hospitals. With the guideline currently, it has the provision for community dispensing, particularly for those clients who are adhering so well in their medication. And what happens is that these clients can be given a take-home dose of 3 months for those who are in the rehabilitation for a period of 3 months, and then those can be refilled. So there is provision for that, such that there is no client who misses the dose at all, because we know what it means for one to miss their dose and what it does to their immunity. Thank you. That's what I wanted to comment on.
Thank you, Damaris, for sharing that information with us so that we know what is prevailing. And of course, with time, new guidelines are given by the Ministry of Health to ensure that the gaps that are being identified are actually filled. And opportunities like this also help us to be able to identify gaps and suggest interventions. Allow me to bring in Boniface to make his comments or to ask his question.
Yeah, thank you. There was a time we had some serious discussion within my board about whether we should take away condoms from our clients when we find them, when we are searching. Should we take them away? Well, one of the taking a pro stand from the family's perspective, that we have clients, we brought them. One of our rules is that there should be no sexual connection or sexual contact while in rehab. It's a cardinal rule of the rehabs. We do not allow fraternization, and as much as possible, we promote a clean environment away from drugs, substance use, sexual activity, and taking away a condom from a client was part of helping them to stay away from that. I was against that because it is, despite all efforts, and despite me agreeing very well with whatever it is that he has raised, there was an evidence that something fishy could go on. As long as you have boys and girls in one center, there could be something that would go wrong. I just thought I should throw this out there to hear what other people may think, or whether there should be a policy. And as far as I think, and maybe Bill knows about this because our prisons also have quite a bit of sexual activity, our prisons, which are both male and female. Yet, I wonder whether condoms are allowed there, and whether we should not take away condoms from our clients. Should be a policy rule or something that you should never take away from somebody, despite the rules. I just wondered what that would look like, or what other people think with regards to that issue. Maybe it's too much for discussion for this one.
You have answered yourself. You have answered yourself. I think that we can put it on the parking and have a discussion around that, or in another webinar probably, where we can even invite maybe other strategic partners to be able to give us what prevails, or it could also advise research. I think it's emerging twice in the discussion, and I feel it is something that can be looked at, but think about it also. Make your comments, then we can make progress.
No, I was just responding to, at the time I raised my hand, I wanted to just respond to what Damaris said. I wanted a clarification rather on what Damaris said about is it written? Is there any written document that shows that persons with who are on ART and are in rehab, they are allowed to pick medication from their nearest health facility, or where there's a provision for the same, for the 3 months duration they are going to be in treatment. Because remember what I started by saying, by the time the client is coming to rehab, a number of them, they don't even know they're going to rehab. We know the complexity that surrounds addiction treatment. So by the time they are being brought, in most cases, it is involuntary. So and they start making the changes in, they don't have place. But you see, when you go to pick for them, or when you take them to pick the medication, one of the things is what they say, they will want collaboration or a transfer note from the other facility indicating that now this person is going to be away for this period. And we know our country as it is. We know the systems that are there. It is not very, it is not harmonious per se. So you will find that if you follow that procedure, this person will end up not having medication, because they will say in the particular hospital that is handling now will have to give what they call medication on transit. And medication in transit, they will give you for 14 days as they wait for you to process. And we know our country, we know how things operate, especially with government institutions. Most of our clients will come from government institutions. So even after the 14 days, the person will not have gotten the letter indicating that given this other institution, they go ahead to manage the person. That's why I was saying, is there something written? Probably you can share with us, send it on the chat, that probably it can help us moving forward with them. If there's none, that is what I was saying, then we might want to have conversations with these institutions and see how to make the process less cumbersome for our clients. Number two is what Boni has said. That's a very interesting. I was really waiting to hear what the response would be, because it has always been a question. And you see, they are away for 3 months. One of the things you'll keep hearing coming up is the conjugal rights. It is their right to have the conjugal whatever. So again, I was looking forward to hearing what is the position on this particular matter. Although from a medical perspective, the medical perspective, I know there's the aspect of a person is admitted in hospital, they are unwell, they need time to recuperate, they need time to follow through with treatment and etc. That is why the conjugal rights are not availed in a hospital setup. But us being rehab facilities, what governs or what safeguards the institution in terms of this particular area?
Wow, that sounds complex, but I believe if there is somebody with a concrete answer in this platform, I would wish to hear from you, or would wish you share your experience, but not just suggestions. We need to be able to hear what prevails, what documents support probably what you are saying. Damaris, you want to weigh on this?
Yes, I want to encourage the rehabilitations. Please have contact. You talked about the key stakeholders. Have the contact of the SASCOs and the CASCOs in the county. These are people who are in charge of the HIV, such that when you have a client who has issues of HIV with you, these people are going to help you and not connect you well, because they know very well that these clients needs medication, and because of if they miss out on those medications and the process, automatically you understand about the opportunistic infections that may arise. So I will encourage, wherever the rehabilitation is, please ensure that you have contact of the focal point persons in the county. These are the CASCOs and the SASCOs within every county, because they take matters of HIV with seriousness about the client, and they are going to assist you on how your client who was brought in not voluntarily, and most probably their family members, even they don't know that this client is HIV positive. And again, it is not the responsibility of the rehab to disclose the status of the HIV status of the client to their families if they have not disclosed to them. So if you work with CASCOs and SASCOs within our sub-counties, I believe access to the medication is so easy. And secondly, if the client indeed tells you that this is the place that I was getting my medication, what I have seen in some hospitals, it is not a hand for them to give that medication for the client for the period of time they will be in your facility. It has happened. I've worked in facilities where, of course, we have facilitated that, and it has worked very well. If only you go through the CCC and you have the right place. But what majorly I will encourage, let every rehabilitation have the contact of the sub-county HIV focal point person within the sub-county and the counties. We are going to get the right information and the assistance, because we want our clients to be healthy and not to develop opportunistic infections when they are in the rehabilitation, which again is going to be a serious problem. That's what I can say for now. Thank you.
Thank you, Damaris. I see Dr. Thomas as his hand raised, but I would want him to tie the comment he was going to make with the strategy that would really make us improve in the services that we are giving, and also see better outcomes, handling matters HIV, sexual gender-based violence, as well as substance abuse, which is really our mandate. As Dr. Thomas prepares to speak, I want to really appreciate a participant from South Africa, Mkolisi. Thank you for joining us. Thank you for being part of this webinar tonight. We really appreciate your presence, and also probably would want to hear your comments or the scenario in South Africa as concerns what we are discussing. Are you in a position to talk, Mkolisi? Okay. Okay, let me give it to Dr. Thomas. Move us forward. And Damaris, kindly lower your hand. Damaris, lower your hand.
Thank you so much for the opportunity. The discussions are really interesting. First, the question about HIV prevention, testing and treatment within rehabilitation centers. I think this is one of the capacity areas we need to continuously work on between the rehabs and the health facilities in those locations. For instance, we ask ourselves whether at the rehabilitation centers, do we promote access to HIV testing Do we promote access to prevention methods within the facilities? Within our clients, do our rehabilitation clients know their own HIV status, and are they able to access treatment if they are HIV positive? So indeed, it's something that we'll continuously assist each other in trying to build that capacity. But just to reflect on that, on why that is important, you are aware that the UNAIDS usually set targets for different countries. For many years, we've been talking about 1990 that ought to have been achieved by the year 2020. That target was then revised to 95, 95, 95. And what this basically refers to is there are certain milestones that countries ought to implement and reach. So for instance, the first 95 that we talk about is 95% of the population has access to a combination of prevention methodologies. So for example, if depending on your own age and status, depending on your location, what prevention method can you access to? So things to do with like male circumcision, access to condoms, access to pre-exposure prophylaxis, access to post-exposure prophylaxis. So in looking at these combination prevention methodologies, that's the first target, that 95% of the population ought to be able to access a combination of these prevention methodologies. Now, when you look at our own counties and sub-counties, we may ask ourselves, the population in our communities, do they have access to these combination prevention methodologies? So that's something to reflect upon. Also for our facilities, our rehabs, do our clients have access to prevention methodologies? The next 95 is 95% of people living with HIV know their HIV status. I worked in Swaziland for 5 years. And in Swaziland, there was a study that used to be called SHIMS study. Now, SHIMS study, what used to happen is that our houses would get barcodes, and then those barcodes would be scanned onto Google Maps, and then we would have a household survey that included us filling in a questionnaire, doing TB screening, doing HIV screening, screening for diabetes and hypertension. And the screeners would basically be a nurse and a lab technician. And they would visit houses in the evening. And over the years, they were able to compare the prevalence of HIV because they have the information about a household. So they say, for example, we tested you in 2016, 3 years later in 2019, they come back to the same household and they do the same type of testing. The interesting thing is that with this type of study that they were doing, they've been able to surpass the UNAIDS targets. I think it was the first country in Africa to surpass the 90-90-90 target. They've also been able to surpass the first 95 target in terms of access to HIV testing. So indeed, they are able to demonstrate that this is possible. Of course, in our setting, it can be expensive because in that country, they only have close to 1 million people. So it's quite easy to do such a study. But in Kenya, it can be expensive. But in terms of the demonstration, they have demonstrated that it is possible for 95% of persons living with HIV knowing their status. The other 90 is that of these people who know their status, 95% need to know, of those who know their status need to initiate treatment. Again, within integration with other services, we might ask ourselves, amongst our substance using clients, how many know their status and how many have initiated access treatment for HIV. Then again, after the initiation of treatment, the other target is that 95% on treatment have viral suppression. So of course, when someone is put on ARVs, there are certain indicators that the doctors look at to see whether the treatment is working. We do viral load. So this is really a measure to know in terms of the viral suppression, has this individual been able to achieve that? The doctors also periodically would measure CD4 count. They might do a full hemogram just to understand the health status of the individual. So again, that's the other target that has been put in place. And if you look at, as Paul had mentioned at the beginning, that there are those who are on treatment and they're using their substances, using alcohol. We might find again, alcohol use or substance use is going to affect the viral suppression. Bill has talked about metabolism of the drugs, and indeed the individual might not be able to achieve this. So of course, as we do substance abuse counseling and treatment, we are also helping the individual to achieve viral suppression. Then the other target that is also looked at is in terms of transmission. Yes, we have captured those who are HIV positive. We have put them on treatment. Now we want them also not to transmit to others. So again, there's a target in terms of the coverage of services that prevent transmission. And here, the target is that 95% coverage of services for eliminating vertical transmission. So of course, this is also a challenge that our governments have in terms of helping the population to achieve this. Then the last 95% is about 95% of women access HIV and sexual and reproductive health services. So again, you find that this also involves a lot of integration. When you look at these statistics and we want to relate with other issues, so HIV with substance abuse, it will involve a lot of integration at the prevention level, integration at the treatment level, integration at the service delivery level, and also integration in terms of working with individuals and families. And so this is a challenge that as substance abuse specialists, we are then presented with, can we be more integrative with the other services? So the question, for example, when you ask about health centers within the sub-county having problems to provide commodities to clients in the rehabs. As our colleagues have suggested, getting in touch with the DASCOs or the CASCOs so that at least we can have these kinds of discussions, because at the end of the day, us enabling our clients access these services overall improves the outcomes that we have in terms of these targets. It improves the outcomes for the clients at the individual level, but it improves the outcomes for the population at the country level. The other thing that I just wanted to mention is that these commitments are normally made between governments to see are we achieving these targets as part of the SDG targets? Because you'll find in terms of HIV services, in terms of integration, and in terms of the social enablers, there are those expectations that we ought to have achieved by the year 2025. So it's a good thing that we're having this discussion as ISSUP, because indeed we are helping the country, we're helping the population to fulfill this promise that Kenya has made to UNAIDS, that 95% of testing and treatment targets are going to be achieved within our populations and different age groups, that 95% of the women of reproductive age have access to HIV and SRH services, that 95% of the pregnant and breastfeeding women living with HIV have suppressed their viral loads, that 95% of HIV-exposed children have been tested and put on treatment by the year 2025, and that 95% of the population of people at risk have access to HIV infection, appropriate prevention options. So whether someone is a substance user, whether someone engages in risky sexual behavior, do they have access to a combination of prevention options? So that is the promise that our country has made to UNAIDS, and that is the promise that we as professionals are helping the population to achieve. The other promise is about integration, that are we adapting our services to the population of persons that come to our facility? So if indeed we are having clans who are sexually active, if indeed we are having clans who are HIV positive, have we adapted our services to integrate their expectations? So here we are looking at integration of HIV services with other communicable diseases, with non-communicable diseases, with gender-based violence, prevention and response, with mental health, and also other services, because at the end of the day, you realize that as professionals, we are also contributing to general health and well-being of the population. So that is what I just wanted to contribute as we continue with this discussion. Over to you, Pamela.
Thank you, Dr. Tom, for those great insights. And I still will tell us that Dr. Tom is also a trustee of HIAS, and you can hear the experience and the wealth of knowledge that as ISSUP we are able to tap from these great men and women. Thank you for bringing us to look at issues integration, especially of services, strengthening capacity, and ensuring that or thinking about how the service providers can tailor the services to the needs of the populations that now we are experiencing. You know, change over the years, what was prevailing 10 years ago is not prevailing today, because evidence has emerged that shows otherwise, or other practices have come up that show that we have to really adopt to what is current, so that we can be able to make meaningful change to the populations that we are serving. Thank you so very much also for bringing us to remember that as professionals, we are not operating in a vacuum. We have the Sustainable Development Goals to respond to. We have the Vision 2063 for AU. We have our blueprint as Kenya, the Vision 2030, and many other documents that really speak to health, considering that our area of operation is a health element. So it is important that we lay emphasis that whatever we are doing, we are really contributing to the wellness of the globe, to the a good environment that our people, our populations can be productive and reduce the burden of health that is really a big challenge, considering that especially in Africa, we have other challenges. We have conflicts, we have poverty, we have food security, we have a lot of other challenges. So if we can be able to make our contribution to the area of health and seeing the interlinkage between all the other health aspects to the population of Africa and sub-Saharan Africa, really will be doing a great deal of work. And that's where ISSUP comes in, to be able to ensure that the professionals who are doing these interventions have some level of skill, some level of knowledge, so that then we are not doing harm to our people. And also we are not getting overwhelmed because we don't have the relevant skills on the knowledge and the standards are not being observed. And that brings me to the bit of trying to find out from APRAK, how then can APRAK work with ISSUP to be able to support the persons that are offering services at in the various rehabilitations that are your umbrella body to, so that then we can empower them and even possibly have them get certified if they are not. So what is the situation, Boniface, and how can you link ISSUP with the APRAK network? Boniface.
Yeah, thank you very much. I have no doubt whatsoever that we need a match, because it's in our interest. Most rehab centers, it's in their interest to have all those things that Dr. Obulutsa have mentioned, an integration of the services that we provide and the sharing of information that we need to. It's part of our strategic plan to work very closely with ISSUP for this. I might want to suggest that in the coming year, and this is something that we need to really schedule out, a series of trainings and conversations between APRAK members. There are two levels of care. One is the management and ownership of the treatment centers, and two is with the staff members of each of these centers. A direct relationship between the service provider, the actual service providers, the addiction counselors, and even support staff, and other support or connected service providers, and a training schedule or a system in which in 2023, Daktari, we can sit with you and your team and agree on this schedule. Some of the things, of course, I can touch base back with my client, with our members, who would also fill in on what they think would be good areas of training that we can pass on to you. That's the first thing coming to mind is that, because this forum, for example, I feel sad that many of them haven't showed up, and we need this for sure. We do need. We deal with these clients all the time. We have to find a way in which, one, we encourage them to show up, two, we empower them, three, we give points if needed. I think that's something I really am looking forward to in 2023 as one of the ways in which we engage with ISSUP with regards to the quality service. We can even sign a memorandum of understanding with ISSUP for this component, especially when it comes to the professional aspect of our services. That's the first thing that comes to mind.
Thank you. Okay, thank you so much, Boniface, for that response. It is an open platform, and I am sure the ISSUP members here, the good thing I can assure you is that we have professionals. We have people with a lot of knowledge and skill. We have people who are offering services globally. You know Kenya with the resources. So when we engage with APRAK, I can assure you these trainers that are global trainers that are certified at one level or another, who are ISSUP members, will be able to render good service to APRAK. And I'm sure that, as we have said, we network. As we come to a close, Mase, can you kindly, you could mute? Thank you. As we near the close of this webinar, I noticed that we have Director Yvonne, privileged to have Director Yvonne from Nakanda, who is also a member of HIAS. I would want to ask Yvonne to say something before we wrap up our webinar. Director Yvonne, you can hear me?
Oh, hi everyone.
Hello.
Thank you. Mine is just I came in to learn, and I'm glad I've had the different presenters and the discussions. And I'm glad we are a team. Let us continue sharpening each other. Thank you, and back to you, Chair.
Thank you, Director Yvonne. We are truly honored, and as I have said before, I remember I mentioned to you today in the meeting, as HIAS, we look forward to engaging more with Nakanda for our services or our mandates do not contradict one another. We are actually looking forward to how we can complement so that we serve our society better. So anytime, Yvonne, there is something happening at Nakanda, we can draw from this network of professionals that are available to render their service to the community in Kenya. Let me allow Elizabeth to say something. I can see your hand is lifted, Elizabeth.
Yes, madam. I was kindly asking what does one need, or what qualification do I need maybe to become a member of ISSUP?
Great. This is a very good question, Elizabeth. And we shall be rolling a video in a short while to tell us what ISSUP, who ISSUP is, and Catherine is on board. I'm sure we can be able to interact further and reach out so that we respond to Elizabeth and many others that could be interested in joining HIAS. And there are various categories which you learn about so that you can know where to enter or to join from. Thank you so much. I realize that there are conversations going on in the chat, and in case there is anything that has not been responded to that is in the chat, Halbert will bring it to the fore so that then it can be responded to. I wish we have been here for well over 2 hours now. As we bring this to a close, ISSUP mandate is to offer training among in the network, ensure that professionals have built capacity and knowledge, and so that this can be able to drive the profession forward. And I know that we look forward to how we can even relate more with the Ministry of Health and all the organizations that are dealing with health, considering that all these things are cross-cutting and we are looking at empowering our society. So as ISSUP, I would want to ask from the panelists to be able to give a final word of where they see this profession in the next few years, and especially what are the strategies that we can put in place to ensure that our services are strengthened and that we are really having the right impact in the community called Kenya. As we wrap up, let me hear the panelists give their view. I begin with Grace.
Okay. I think there are many things that we could propose. I'll just mention one or two so that we can ensure that we are moving in the right direction. I believe we can actually do more trainings on specific issues. Like now what Boniface is was saying, we can enhance this section, because one of the challenges that we are having across the board is the fact that there is some level of knowledge that needs to be provided to our people, not necessarily even for training, even for themselves to take cover. So I want to imagine that we need to come up with a campaign, a serious campaign that surrounds on how we need to train and even encourage those that are already in the field, even to be certified. Because at the end of the day, we need to even know which area are we good at specializing. Tonight we have discussed integration of various issues, but at the end of the day, we also need to be encouraged to specialize in one area, even if you can do all this. So I want to imagine that there are many levels that we could approach that, but I think one area that we need to work on is the area of training, the area of sharing knowledge, networking more, such like the way we are doing, and even encouraging ourselves, because at the end of the day, we have an impact. The other challenge that is also very key, even as we move forward, is to kind of do more of, I don't know how to put this, but it is like we may need to see how we can we can have specific various stakeholders that for quite some time have been kind of not left behind. For instance, like today we are talking about issues of our adolescents, and we know very well that these adolescents are under the care of the family. I mean, of our families. And we have a situation whereby when we look at the issue of the family unit, we do have those parents down there. And until we are able to speak to the family unit, we may look for very many strategies out there. But for me, I think we need to look at the parenting in a better way, because so long as a family is not using the only one that is good, of course they are four. But if somebody is just using the wrong one, like for instance, now we are talking of some families, you just find they are so in the use and the neglect, a type of parenting. And yet, like now we are saying, we are going for holidays, and already there are some parents who are really complaining. We are having children for 2 months, and it's like, it's a big deal. So you ask yourself, where are these adolescents supposed to be? So we are having a kind of a big issue, starting from the family, where most of these problems need to be addressed, so that apart from us becoming specialists in addiction and maybe HIV and all that, we may need to relook at our society in a different way and ask ourselves, how are we going to help the parent to actually take their responsibility? Because we all know the only thing that you are not allowed to delegate is parenting. But we are having quite a number of family or the parents actually delegating this role, and that makes us now to have a defeatist way of addressing these issues. Because for instance, we even as we move, we know that if nothing is done, there are so many young people who are going to get pregnant during these holidays. Yet, if the parent was to take cover and do their responsibility, then we would not have a lot of problem. So for me, I would think we need to look at these issues in a more holistic way, and even involve more stakeholders than we have been doing, because maybe we are dealing with the symptoms, instead of dealing with the real issues. And then we also need to see what can we do, because the issues at hand, they need to be approached more from a community point of view. We need to see how the community can even be encouraged or to be involved so that they can even come up with those wellness programs wherever they are, those open healthy talks, so that we empower our young people. Because even at the workplace, even when we are saying we have challenges in the workplace, the new what we call millennials, the new young people that are joining the workforce, they are the ones who seem to have a lot of challenges, even in the 3 issues that we are talking about. So we have a lot to do, because unless we empower our own children, they will not be able to make informed choices. And it will be so difficult for us, because at the end of the day, they are more than, you know, when we look at the statistic, they are many in numbers, and yet if we are able to involve the family, we are able to actually even ensure that even in the school, a lot can be done because they are in numbers, then we would actually be able to make it even easier for us who are professional. Otherwise, the way things are moving, it is a great concern, because everything is going to build or to finally affect the mental health of most of these Kenyans. That is exactly where we are. And even as we move on, it is like we need to actually work in a smarter way, rather than just moving up and about. So for me, I think there is a lot to be done. We may even encourage ourselves to do more research, because without real data, even specific to our own, I'm glad, like today we are saying, there is this group below 15 that we have not been able to capture. Yet we have been on the know-how that occasionally we are finding very young children in the vehicles, all over, drinking and doing all manners of behaviors that can actually expose them to the HIV infection. Yet when we look at our statistic, that is not, it's not being well captured. So we have a lot of challenge, but ideally we need to also encourage ourselves as professionals, because there is also the way we can get some burnout. So we also need to, as we help, what is there for us, so that we don't also get lost along the way. At what level, or at how, I mean, like when I listen to the panelists that work in the rehab and all that, how effective are we taking care of you? Because we might actually find ourselves at the end of the day, you are also having a lot of challenge because of what you are going through. Because basically, our work is very it's draining us a lot emotionally, and I don't think as professionals we are at a level whereby we can be proud to say that we are really taking care of ourselves. And I think this is a great concern, because in that combination, we need to also be very careful and ensure that we have that supervision that is required, the clinical supervision, so that we also don't get swallowed in the whole mess. Otherwise, thank you so much. I believe there is more that we can do. Yeah, thank you.
Thank you, Commissioner Grace, for sharing that. Grace is in charge of training and credentialing in ISSUP Kenya. So when she talks about the capacity, it is really because that is the focus we want to take to ensure that as many as possible are trained and credentialed, so that then we standardize our service. And I like the fact that you are tying it with the Olin Day that we are in. And I would like to hear the same also from the panelists in a very simple way, for the sake of time. just 2 minutes or so, be able to tie your submission, your final word, with the fact that we are in a long holiday. It's a period of celebration, opportunities to have substance likely be abused. Some people get initiated to use during this period of partying and celebrations. So let me call upon Paul to speak to this as well. 2 minutes each so that we can be able to close. Paul? Paul seems to have left. Can we have Boniface, are you around? Oh. Okay, Dr. Thomas, I can see you.
Thank you very much for organizing this session today. It has also been a learning experience for myself, and I believe for the rest of us. Maybe what I would say as part of the closing is to increase on our networking between the substance use professionals and also healthcare professionals, especially for our clients who are either exposed to HIV or are already on treatment for HIV. So increased networking. Thank you so much.
Thank you, Dr. Naomi. Naomi, unmute.
Okay, thank you. For me, what I was trying to look into that as we look at the protective measures, having our young children at home, we need to encourage the parents to be more involved in terms of monitoring and supervision, ensuring that they know what their children are doing or have been doing by actually just checking around the rooms, you know, and understanding the type of friends their children are having. And then we also have the communication within the families where we can be able to discuss issues of drugs, HIV/AIDS, and even issue of that we should continue being open in terms of talking issue of sex, not look at it as a taboo. And then we also have more community involvement, being able to discuss in our chama, creating awareness in terms of HIV and AIDS and the substance use within those groups. Because the more we reach out with the information, the more people will be more aware of what is happening. And then we can also use other avenues like the churches and where we can be able to talk to our young people, have seminars, you know, or rallies or walks. And then at the end of the day, we can be able to discuss issues of drugs and HIV/AIDS. And that way, again, by the end of it all, we'll have had an impact in the community when we discuss all that. When people get to know what are substances. Some parents, when you talk to them about substance use, others do not even know bangi na fananaje, you know, those kind of things. But when they are able, or even they are taught this is how it affects and things like that, they'll not just wake up one day and realize, oh, my child has been like this, because they're already well informed. So we need to look at the parents, we need to talk to the community members, the churches, wherever there's a gathering, chief barazas, whatever opportunity that we have, can we talk about substance use and also HIV and AIDS? Thank you.
Thank you, Mulee, for bringing up the strategies to the family so that we can be able to help parents to intervene or identify likely challenges amongst the children, especially during this holiday, and bringing the aspect of networking. We need to network more as ISSUP so that then we can be able to harness the resources that are available in terms of the networks in the country. Allow me to bring Boniface to say his final word and tie it with the holiday. I know as a parent, I don't know if you are worried, like some I saw on the TV, wondering where they will take the children for 2 months. I don't know if it is your case. Is the same case applies to you, Boniface?
Actually, today my daughter was telling me that in certain countries, she's only 12, in the countries like Indonesia, a girl child has the right, the right of consent at 12 years. She can, God, it was a very hard discussion to have that. So yes, we have challenges. Parenting is not, and I want to thank Yvonne and kind of this. I remember last year they developed guidelines around prevention programs that have not been really looked at. I would really personally haven't read those guidelines. I'd like to have them. But this is what I would encourage. Engaging our young ones and development, just like Wanjiku Grace has really put very well. We need to invest in our communities, invest in programs that invest in actual programs, not just talk, in programs in almost every community that helps prevent addiction and highlight mental health issues and positive psychology. Because a friend of mine was telling me today, you know, a lot of that cycle that you talked about, the poverty cycle, goes with like what the governor yesterday was saying, the time between sex being among the young poor population, the only activity that is enjoyable, because the other things they cost. So if we were to help in every community in this holiday, engage our young people positively. They should not just be wachwaduko, apoeke, they start getting, engaged in things that are trying to make fun, they're just bored. And that is where the cycle keeps continuing. It's almost like a cycle of early childhood, traumatic events in early adolescence. They get children when they're young, and the cycle of poverty just takes on a root that the breaking of that cycle is always very difficult. So I'm just hoping that we can engage in these populations, put our money in programs that help the younger population, the most vulnerable of the populations, and see whether a positive twist to their engagement, which has been known to work in other countries, would work for us too. I'm sure that our communities, our regional cultural communities, had very proper programs around young people. I don't want to talk too much, maybe because we have talked enough. Thank you.
Thank you so much, Boniface, for bringing that out. As we come to a close, I want to wrap this up by reminding us as ISSUP that we need to strengthen our network. And I call upon each one of us, at least a professional somewhere. Boniface, I know members in the APRAK who need to join this profession. So I'm calling each one of us to take it a challenge upon ourselves in the next coming year to at least bring along 5 to 10 members who are practicing out there who are not members of ISSUP, so that we can strengthen our membership. The stronger we are, the better we are able even to mobilize resources to work around the gaps that we have identified. Also to bring us to know that next year we would want to have a calendar of activities that the executive will be working to ensure that at least we have activities outlined for the whole year. We have opportunities to present webinars as a region, Africa twice. I think I think every quarter, so we need to have members of HIAS indicate what they would want to present to the global platform, so that then we are captured within the beginning of the year, so that we don't lose those opportunities. We would also want to relook at our constitution. The constitution that we have was made generic for registration. So there is a task team that is working to modernize it, to bring it to the contemporary issues. And this will be presented to us so that we can give our input. It is our society, so that we have a constitution that is alive and current. We are also working to see that we have a strategic plan as an organ, at least a 3-year plan or even 5-year plan, that as work plans, activities outlined for every year. And we are calling upon you to make this contribution, so that then we can have a strategic plan that will take us to the next level as ISSUP. I want to take this opportunity to really recognize those of us who have not talked, and Kamonde, Beatrice Mainge, Beatrice Mainge. I'm just taking note of those who have not gotten an opportunity to speak, but who are part of this. Elizabeth, I'm sure you have spoken. Somebody called Galaxy 872. We really appreciate you are staying on to the last minute. Masikanywa, Masit as well, Mumbi. Thank you for staying on up to the last minute. We have Nancy Murigu. We really appreciate your presence. Patricia Kimani, thank you for staying on through. Ronald, Sami, Dr. Sinkele, thank you. Teresia Jora, thank you for staying on up to the last minute. And our very strong member, Fatuma Musau, thank you for being in the house all through. I want to take this opportunity as we bring this to a close to ask Albert to say something. Albert is very instrumental in webinar. Is our PR person for HIAS. Every publicity you see passes through Albert. He has really given a good service to this organization, using his skill, using his knowledge, using his time to ensure that the webinars are running. He has coordinated us so very well. So Albert, I will ask you to say something as we close, and as well as take us through the short video of ISSUP, and then we are able to close. Albert, and please show your face.
Yeah, Madam President, thank you for the opportunity to share something. And yeah, thank you for this very well organized and coordinated webinar. There's so much there to pick up from all the presenters who are also skillful and so knowledgeable in this area. There is so much more to talk about. I have recorded the chat, and so I'll be sharing that. And there's some pretty good ideas there. And so, yeah, I just want to say thank you to everyone who sacrificed the time. I know the notice was not long, and we really do appreciate your presence and your participation. So, Madam President, thank you so much for initiating this and driving it. It wouldn't have happened without you. And I'm just amazed even by your skills as a moderator. You have another career there. So I'll just share this short video, which I've already shared at the beginning, but I'll share for the sake of those who had not yet seen it.
ISSUP is an international professional society that connects, unites, and shares knowledge across the global substance use prevention, treatment, and recovery support workforce. A key element of ISSUP's work is our international network of national chapters. They connect ISSUP members in their own countries and help adapt the role and mission of ISSUP for different languages, cultures and environments. National chapters bring together the prevention, treatment and recovery support workforce at the national and local level. Each country presents its own set of challenges and opportunities for developing a trained and well-connected workforce. Our approach involves partnering with local organisations to establish national chapters that offer a wide variety of activities to those working in the field. National chapters act as a focal point where members can get knowledge, training and valuable networking opportunities. For example, they provide members with a space to learn from experts in their own country and share knowledge through online webinars and in-person events. They also help to change the way that research is communicated and used by the workforce. By guiding and supporting effective research engagement, national chapters make a vital contribution by helping to ensure that research evidence reaches and informs policy and practice. These are just a few of the ways ISSUP national chapters are making a difference, and we invite you to join us in shaping effective, ethical prevention, treatment, and recovery support services where you live. It does not matter what stage of your career you're at, we look forward to welcoming you. Becoming a member is free and it's easy to apply online. Visit our website to learn more about our national chapters and the benefits of joining ISSUP.
Great. Thank you so much. Now we have some video that we can be able to share even as we introduce people to ISSUP. This is a global platform, but even as people register to the global platform, we want to recognize those in the national chapter so that then we can be able to grow our national chapter. Because being in this nation, we have to be able to contribute to what is happening in terms of prevention, treatment, and drug demand reduction, because it really counts. It is cost effective to prevent. It is cost effective to be able to integrate these aspects into the matters health for our population. So you have a job well cut out. You are very important as a professional because you contribute to the growth of our nation. The value that you are handing really cannot be overemphasized. So I encourage you to build your capacity. I encourage you to take care of yourself. Personal development, very, very key. As Grace brought forth, it is important to have clinical supervision so that then you don't offer services to others and then you break down as an individual. We need to have you live long so that you can be able to serve this country even more. So I wish to bring this to a close by saying thank you so very much. We hope in the new year, we can be able to line up many of such platforms that we can share. And especially once we be able to pick out all these issues and gaps that have emerged and maybe have national webinars that even if it is once per month, responding to one issue or another. I'm sure at the beginning of the year, this should be able to be rolled out so that then we can work together as a team. I wish to wish all of you a Merry Christmas and a wonderful new year. In case we don't have another opportunity to meet as the entire membership of ISSUP Kenya, know that you are valued and enjoy the holiday. See you in the next year, 2023. Thank you and God bless.
Thank you.
Bye-bye. Bye.
Bye. Bye. Bye.
Bye.
Bye.
Bye. Bye-bye.
Goodbye.
Bye.
Madam President, can we take a photo before people leave?
Ah, you have let them leave.
Stop leaving people. Let's take a
Stop
photo,
leaving,
please.
please. We take a photo.
Put your cameras
Put
on,
your
please.
videos on. Put your videos on. I wish we could have everybody back. Sorry. Okay, your videos on, the 22 of us who are around.
Smile.
Don't leave, and you smile. Grace.
Yes. Again. Smile again.
More.
Nancy, please put your camera on. Teresia.
Yeah, let's have my cameras on.
Sammy, Ronald.
Editor.
Editor. Ndungu.
Ndungu is false.
Okay. Charles. No, Charles is okay. Charles. Sammy.
Ndungu, your camera is not on.
You can see Kirungu is on.
Yeah, we can see Kirungu.
Oh, okay.
Ronald, Sammy, Fatma, Mombi. Oh, Mombi's on. Okay. Fatma.
Wycliffe.
The last one.
And Ronald.
Okay, Mercy is come on. Good. Hivo. Thank you so much.
All right. Thank you.
Thank you.
Good night.
Okay, bye-bye. Bye.
Good night.